I think it's something that is recognized by both internal medicine and nephrology as something that our trainees should be learning. We just need to have the infrastructure to do it. And I think as, our generation of doctors kind of rises up, I think that infrastructure will grow further. But I honestly, I can't imagine practicing without it.
Welcome to Corium. We have a special NephMadness episode today, and you just heard from Dr. Jeffrey Cott.
Hi, my name is Jeffrey Cott. I'm a nephrologist and intensivist at Mather Hospital, which is part of the Northwell System on Long Island. And I'm also part of the NephMadness Executive Committee.
And I'm also here with Dr. Noah Markowitz.
Hi, I'm Dr. Noah Markowitz, a PGY3 internal medicine resident at Montefiore and soon-to-be nephrology fellow at Mount Sinai. I'm personally beginning my own POCUS journey, and I'm thrilled to share some of the amazing teaching points we learned from Dr. Cott.
Yes, and before we get started, what is NephMadness and what are we doing here today?
So NephMadness is mirrored after the March Madness college basketball tournament. And the goal is to award the topic that we think is going to be the face of nephrology in 2026, the most influential or most exciting thing that's going to happen in the years to come. So a bracket's going to be made of different concepts in nephrology, and these concepts will then go head to head with each other. The winner of each matchup is decided by a panel of experts. I can say that I look forward to NephMadness every year because there's so much content released from it. Experts write blogs. I feel like I go through a mini nephrology fellowship every March.
Aww.
And of course, there's the podcasts.
Yes, which is why we're here today. So today we're talking about what is going head to head in the Northeast region bracket, which is point of care ultrasound, POCUS. And the matchup is between POCUS for AKI versus POCUS for end-stage renal disease.
So we're going to be going through 4 cases, the first 2 being POCUS for AKI and the second 2 being POCUS for end-stage renal disease. So as we go through these cases, think about what you want to vote for as the future of nephrology.
All right. I think, Jeff, we're so excited to learn from you today and why you're so passionate about ultrasounds and kind of some of the cases that have made you think, I'm so glad I have these skills. And for listeners, all these cases are de-identified.
So our first case is a 71-year-old male with a past medical history of BPH with prior hydronephrosis, diffuse large B-cell lymphoma, currently receiving RCHOP, who's here with abnormal labs from his oncology appointment. He received his last chemotherapy as an outpatient 3 days ago and was found to have a potassium of 6.7, a creatinine of 4.5, which is a big jump because 3 days ago his creatinine was 1.1. They got more labs in the emergency room and showed the potassium was up to 7. The LDH was over 1,000, phos was 6.7, uric acid was 12, and the calcium was 8.8. The patient states he's been passing urine without any issues.
Yeah. Wow. That creatinine jump is impressive, right? He was somebody that lived at 1.15, then went up to 4.5. And then in the ER, they got all these other labs, a potassium of 7, and LDH in 1100s, a phos of 6.7, the uric acid of 12. I mean, this is just screaming tumor lysis syndrome, TLS, in a person with diffuse large B-cell.
Obviously, when we're getting this call as a nephrology fellow, your first thought should be to go through your pre-intrinsic and post-renal causes. Always keep those in the back of your mind. But in this case, TLS was certainly high in the differential. With TLS, the reason why that matters is because you might be a little quicker to pull the trigger on kidney replacement therapy. If you're unable to keep up with the intrinsic potassium generation, you're going to have to be a little quicker to pull the trigger on dialysis. So when I was seeing this patient, I was really just looking for a reason not to dialyze him.
So when the patient tells you that they're passing urine without issues, are you kind of done with the post-renal bucket?
Yeah, it's a good question. I think the answer is no. I've seen enough patients tell me that they're urinating okay and then wind up having, full bladders or hydronephrosis on ultrasound, or, sometimes they're just endorsing incontinence, but just not really kind of acknowledging it that way. So, yes, it may make my suspicion a little bit lower, but it doesn't entirely rule it out for me.
So let's kind of enter POCUS into this. In my mind, you can ask the nurses to bladder scan, you can get a formal renal bladder ultrasound, and then you can do your own POCUS. So what's the difference between the 3 and how are they each helpful?
Yeah, so a post-void residual or just a bladder scan is, going to be fairly easy and probably would be enough to rule it out. The one issue I will say with that is, in this case, you're asking a nurse to do that. But in this case, this was a fairly busy ER. I, could have asked the nurse. She had many other patients. It might have actually taken a little bit of time to actually get done. And then they have to actually be able to report it to you. You may not be at the bedside anymore. So, post-void residual bladder scan is completely fine. It just has a few drawbacks in my mind. Renal bladder ultrasound will obviously be our gold standard. The issue with that, depending on the hospital, is one, it can take a little bit of time to get to. They're also a little bit on the more costly side, potentially. Some kind of studies say that, it can be between $200 to $1,000 per scan. So that leaves with the ultrasound. If you have an ultrasound available and obviously have the confidence and skills and ability to actually perform your own kind of renal bladder ultrasound, it's something that you can do relatively easily. One, it's fairly sensitive and specific compared to our gold standard, our renal bladder ultrasound or CT scan. And two, the time that it takes to actually get done can be hours to days faster. So, for me, if we're in this situation, I'm reaching for point of care ultrasound because I think it's going to be the quickest thing and it's going to get me my answer fastest.
Yeah. And thank God you were thorough, because what did you find doing POCUS?
Yeah. So I demonstrated bilateral hydronephrosis in a pretty large bladder. So at that point, asked the nurse to place a Foley, which she thankfully did quickly. And just kind of watching his labs throughout the night, they did come down and we were kind of able to avoid dialyzing him. In this case, it certainly looked like we really were looking more at an obstructive nephropathy as opposed to some kind of intrinsic cause like TLS.
Awesome. That's amazing. What a great story. Okay, so here we have the power of POCUS, right? He was able to find hydronephrosis and diagnose post-renal obstruction due to BPH. And he helped avoid dialysis in this patient who was on chemotherapy. And at first glance, his labs were screaming TLS, right? And this was also just a good humbling teaching point about labs and severe AKI can look a little bit like TLS, hyperkalemia, hyperphosphatemia, hyperuricemia. And he was able to do all this with just POCUS at the bedside, and he didn't need to get a formal renal ultrasound.
Treya, different hospitals say different things. Do you guys also call that the R-bus?
What? No, what is an R-bus?
Renal bladder ultrasound, R-bus.
I picture like a bus going up someone's renals, but it's not. It's like going through the ureters and bladder. Ugh. Anyways, I mean, we have different things. We say ruckus, so, it's...
Ruckus?
Yeah, I know. When I first heard this, I was like, shake my head. But once you get into it, you just keep saying it.
To not make too much of a ruckus, I think we should move on here. So
Yes.
Now's a good time to talk about when do we actually need to get that renal bladder ultrasound or R-bus. So the Journal of Hospital Medicine has a great things we do for no reason on the R-bus. So we're going to attach it to our notes, but they describe a validated risk assessment tool with things such as history of hydronephrosis, history of recurrent UTIs, and absence of heart failure.
Okay, that's really great because I feel like we constantly write #AKI and like reflexly order that renal ultrasound or R-bus, as you cool kids say. And yeah, I sometimes do wonder, like, are we over ordering this thing?
So the score helps you risk stratify. They recommend always starting with a post-void residual and only in high-risk patients who the AKI isn't resolving should you get that formal renal bladder ultrasound. Due to this patient's prior history of hydronephrosis, he would have met criteria for the renal bladder ultrasound. But what's cool about POCUS is you don't even need to wait for the nurse to do the post-void residual. You can do it yourself while the nurses are busy with their tasks.
Yeah, and I guess that begs the question, if we're going to order this renal bladder ultrasound, is like the big thing just to, hey, I want to rule out hydronephrosis, or is there any other information we can gather from it?
I think if you've got somebody with that elevated creatinine, they've never been in your hospital before, you're not sure if this is acute or chronic, echogenicity, cortex thickness, that could point towards chronicity.
Yeah. And just to close that loop about chronicity, what will the cortical thickness, size, and echogenicity tell you that would say, oh, this has been more chronic kidney disease versus an acute process?
Yeah. So if you were having more echogenic kidney, so meaning if we're going to look at an image, if the brightness of the kidney is similar to that of the liver, that's going to tell you that there's probably a little chronicity, chronic kidney disease. Kidney size as well, which I forgot to mention, if you've got a smaller kidney, but something that theoretically as well could point towards some kind of chronic kidney disease. And then cortical thickness, if you have a thinner cortex, something that's probably just a little more scarred, fibrotic, that also can point towards chronic kidney disease.
And how chronic does someone's kidney disease have to be for us to be able to catch it on POCUS or renal ultrasound?
The answer is you can have a normal creatinine and have those findings. Or I should say, we'll say in quote unquote normal creatinine and have those findings. So it's not I guess we'll say 100%. You can have increased echogenicity with a baseline creatinine. It just may mean somebody's probably got CKD. It just hasn't shown up in the labs yet.
Isn't it
Kind of
like
the
their
same way.
GFR hasn't taken a hit, their creatinine hasn't?
Yeah, it kind of like think about the person who's got, diabetic kidney disease, they got bad albuminuria, and, creatinine's just still normal for them. They haven't had that GFR decline that they will have at some point.
Oh, interesting. Yeah. So maybe those changes can be seen even before the GFR declines. Okay.
Would any of this show up on POCUS, or that's really more for a formal ultrasound?
The answer is yes. I think, honestly, the ultrasound machines that we have are really, really good at this point, that are the portable ones.
All right, let us summarize this case then.
So we had a patient who we were concerned about TLS, which is important because it might push us to do dialysis earlier. But just by using POCUS, we were able to see the hydronephrosis and realize it was more of a post-renal picture, place a Foley, avoid unnecessary dialysis, and avoid misdiagnosing TLS.
Yes. And then to summarize the different types of scans you can use to look for post-renal disease. On one hand, yes, you can tell the nurses, can you help me get a post-void residual? That's good and can help rule out kind of post-renal obstruction. And then on the other spectrum, you can order a formal renal bladder ultrasound and kind of wait for that to come back. But there's this wonderful checklist where we can kind of risk stratify patients so we don't have to order it for every single AKI. And then the last option is we can do our own POCUS.
And the last teaching point I just want to say out loud, just because the patient says they can pass urine, don't be so quick to rule out post-renal.
All right, let's move on to case 2. We have a 65-year-old female. She has a past medical history of HFpEF who is being admitted for a heart failure exacerbation. She also has a history of diabetic kidney disease. Her baseline creatinine lives in like the 2.2, 2.5. Her creatinine on admission is 3. And then day 3 of admission after diuresis, it bumps up to 3.5. Okay. So on one hand, on day 3, some good news is her O2 requirements are down from 4 liters nasal cannula to room air, and she's negative 2.5 liters from admission. All right. And so I think here a lot of people might hum and haw, be like, okay, she doesn't look that volume overloaded. Maybe we can discharge her. She doesn't have any oxygen requirements. Are there any inpatient needs? Or on the other hand, someone might say, oh, man, her kidney is still not back to normal. Is it just CKD progression? Should we stop and think about other causes? Should we diurese more? I think there's a lot of places to pause here.
When you stop is really always a difficult question to answer. Based on this exam, this STEM, this patient seems like they've gotten a lot better. She's 2.5 liters negative. She's not on oxygen anymore. She's looking like she's euvolemic, we'll say. But I think, this is a situation where the exam can lie. I think, we've all seen the data that maybe in our exams, unfortunately, aren't as great as determining volume status as we would hope they'd be. So this is a case where really we're saying, okay, our creatinine's elevated. Sometimes an elevation in creatinine, if you're diuresing somebody, is not a bad thing. It might just mean you're drying them out. Their creatinine is, in theory, we'll say getting more concentrated, and the creatinine's rising without really injury. It's just rising because we're drying them out. But it's kind of always hard to determine, again, are they still wet and they've still got, AKI from cardiorenal syndrome, or are we just actually drying them out? And that's, I think, where point of care ultrasound can kind of come in and help us out in a non-invasive way.
So everyone's familiar with POCUS for the IVC, but I think the newest contribution from ultrasound is VEXUS, where you're not only looking at the IVC, but also the hepatic vein, portal vein, and intrarenal veins to look for any patterns of congestion.
VEXUS, after all, is venous excess ultrasound. So we're looking for essentially excessive fluid in our venous system that ultimately correlates with acute kidney injury. You put pulse wave Doppler over that little red and blue speck, and then that kind of allows you to see renal arterial waveform, not your main renal artery, but kind of your intralobular arteries, and also your venous waveform as well. So you can, again, look for changes in patterns that will indicate whether somebody has congestion or not.
And then there's a scoring system based off the pattern. Can you try to explain the scoring system? Because this is where I get confused.
Yeah, of course. So the scoring system is really going to be, there, and I encourage you to obviously look at the actual images online, because I think that's probably the easiest way to kind of get this. But the scoring system is essentially going to be based on how abnormal the waveforms are. So, you have to have a large IVC. You have to have an IVC that's greater than 2 centimeters to kind of a non-variable to start. And then, depending on what you're looking for is kind of at least one of those vessels that you're interrogating, those veins that you're interrogating, has to have severe congestion. And if more than one has severe congestion, that's your VEXUS 2 and 3. And a VEXUS score greater than 2 is what really correlates in the literature with an acute kidney injury.
Going back to this patient who had some CKD at baseline, creatinine of 2.2, 2.5, day 3 of admission, negative 2.5 liters off oxygen, so some wins, but her creatinine still hanging out at 3.5. Somebody could say oh, well, maybe her CKD's progressed. Should we diurese more? Should we stop and think about other causes? Curious how you applied VEXUS and what the outcome was.
Yeah. So, I think the big thing is drier is always better for people. So on her ultrasound, I had her VEXUS score as 2. It was her intrarenal congestion was severe. She also did have portal venous kind of pulsatility. So at that point, we wound up starting her on a Lasix strip plus a thiazide diuretic, metolazone, and really started to kind of aggressively diurese her.
And then this is what really stood out for me with this case. At the end of this patient's hospitalization, she ended up being net negative 29 liters. And this is just bizarre because I could totally see someone on rounds being like, oh, she's negative 2.5 liters. She's off oxygen. Great. And yes, her discharge creatinine came down to 3.0. So as a reminder, again, it peaked at 3.5 day 3 of admission, but it didn't necessarily go back down to the pre-admission 2.2, 2.5 where she lived.
And then her creatinine didn't get worse. We're always so worried about, are we over-diuresing? Is our creatinine worsening? But in this case, we had somebody who, if we had stopped, it probably would have been harmful for them. So we wound up using a non-invasive test to essentially guide our management and really kind of, again, dry her out.
Yeah, it's so humbling, these cases. Someone could be hiding 29 liters of fluid. And you're like, okay, should I stop after my 2.5? They're off oxygen. I'm good, right? They look dry, but you don't know until you kind of look at some of those veins a little bit closer.
The take-home points for case 2 are obvious. The patient was hiding 29 liters from us, and it was only with VEXUS that we were able to identify it. Before we do this third case, we have to take a transition point here because this whole NephMadness bracket has been POCUS for AKI versus POCUS for CKD. And I'm pretty sold on POCUS for AKI. I don't really see how POCUS for CKD is going to top it because those were 2 good cases.
We'll see. I think we've got a couple more good cases coming up.
Here at Corium, we're talking about the real things that can help anyone who works in healthcare. And today we're talking about how the scrubs you wear, they can make a difference. I remember the first time I saw one of my colleagues walking into a sign-out room looking way more put together after a night shift. And I knew right then and there, they were wearing FIGS. FIGS Scrubs is made specifically for us, doctors, residents, students, healthcare professionals who are putting in long hours and really need gear that can keep up and perform on our level. We have so much going on in any shift, right? Scrubs are the last thing we want to be thinking about. And that's why FIGS is great in that they're lightweight, stretchy, breathable. They have all the small touches that have made me a true convert. They're clean, they're modern, super functional, tons of pockets that I love for all the snacks, zippers that don't snag, and antimicrobial fabric to stay healthy while working. You deserve better scrubs. You deserve FIGS. So head over to figs.com and enter FIGSRX at the checkout for 15% off your first purchase. That's figs.com, promo code FIGSRX for 15% off your first purchase. And with that, let's head back to the episode.
All right. Next up, we have a 57-year-old female. She has end-stage renal disease on hemodialysis. She's anuric, and she also has a history of COPD and this chronic cough. She's at the dialysis unit for her usual dialysis session, and she says she's been short of breath for the past few weeks, and it's really worse in the last few days. And it's not like she's missed any dialysis sessions in between. Her estimated dry weight actually had been recently lowered. It used to be 59 kilograms, is now 57. And thankfully, she's been tolerating that just fine without any hypotension during dialysis sessions. Her blood pressure is 125/83. She's on room air, but she does have these end expiratory wheezes.
I can see this being another hard case because we have a patient coming in with known COPD. We're hearing wheezes on our physical exam. So I'm very excited to hear how you use some POCUS to figure out, is this her COPD? Is she actually just more volume overloaded than normal?
Yeah. And this is dry weight is a really hard thing to kind of handle in dialysis patients. Like you said, this could be COPD, it could be volume overload. She's got maybe some signs of both. Dry weight has been challenging. One, if you lower it too much, people get hypotensive, they get cramps, it's a little difficulty.
Okay, so before we get too much into this case, let's just get into what is an estimated dry weight, this EDW that we might see in nephrology notes, and how is it actually used?
So estimated dry weight really is the baseline for the individual. So, it's something that can be a little, we'll say, challenging to figure out initially, especially when somebody's starting dialysis. Usually they're probably on the more overloaded side to begin with when they're starting dialysis. So it's something that will take a little bit of, time and we'll say a little bit of trial and error as to actually figuring out, but that's going to be the baseline for that person. So like, let's say, one day somebody comes in at their dry weight's 55 kilos and they come in at 57. Well, they're going to get 2 liters off during that dialysis session. Let's say they come in the next day and they're now 57.5. Well, now they're going to get 2.5. So it's kind of that standard of reference where the person will be dialyzed to. So, when you're lowering dry weight, you don't want to just go from 57 to 53 right away. It's something at least you would probably do in a little bit of stepwise fashion, make sure that they're tolerating it still. And then, if they're doing okay, then you can kind of push it a little bit more.
Okay, so how could POCUS help us think through, is this COPD exacerbation or volume overload?
The only thing that's really been studied in the outpatient dialysis setting is actually lung ultrasound. And having B lines on lung ultrasound is actually a risk factor for mortality in dialysis patients. Again, unsurprising, having too much volume on somebody is not a good thing. So, the probably biggest study and probably the most robust study of anything I've talked about today was actually the LUST trial, which came out several years ago. It was a multi-center randomized trial that kind of used a lung ultrasound guided protocol versus standard of care.
To try and simplify this study as much as possible, relief of lung congestion was achieved in 78% of patients in the intervention arm that used lung POCUS, compared with 56% of patients in the standard of care arm. But this did not translate into fewer MACE or reduced mortality.
I think lung ultrasound's probably got the most robust data in the outpatient dialysis setting, and that's probably what I wound up doing in this patient.
Yeah. So curious, with this patient, what did you see when you did POCUS?
So we saw greater than 3 B lines, which are statistically significant, we'll say, for some kind of, again, intraparenchymal fluid in really all lung fields. Also saw an IVC that was greater than 2 centimeters and non-variable. So then we further tried lowering her weight a couple times and did ultimately kind of get her symptoms under control.
To get some resolution on this case, it wasn't until they decreased her dry weight to 53 kilograms that not just her shortness of breath, but also this chronic cough fully reversed.
So what do you think happened in her case? She was anuric. Did someone just misguesstimate 59 kilograms is her dry weight, and then she just lived with this chronic cough and she had COPD? If we were to do a mini M&M on this, right? And maybe 59 was thought to be fine, but if we reassessed, her chronic cough maybe wasn't from COPD, and if we moved the dry weight to what's more accurate and get fluid off, that helped her cough symptoms get better. Is that the takeaway?
People's dry weights can be stable for years, but the issue is that dialysis patients' nutrition can be a little off. So in theory, if somebody's having less nutrition, their muscle mass might get a little worse. And that muscle mass is essentially, if their weight's staying the same, it's going to be fluid. It's going to be water. So even though maybe, yes, she was at her stable dry weight, yes, this cough was kind of getting worse, it didn't look like it's volume. It could be a component of maybe her nutrition had been more poor and, that weight was not muscle mass anymore. Now it's just water.
That's really humbling to hear how just nutrition alone can lead to a lowering of a dry weight. How often are you thinking about reassessing your outpatient dialysis patients' dry weights?
It's probably something that should be done more frequently. You meet with them at least monthly face-to-face. I mean, you see them several times a month, at least weekly, I should say. But, it's really going to be based on kind of discussion with them, symptoms, and what they can tolerate.
And then I think we should talk about kind of the opposite situation here. We see patients come to the hospital all the time for intradialytic hypotension. So is there any way POCUS can help us out in those patients, or to kind of risk stratify those patients?
The answer is there are some ultrasound findings that do correlate with that. I mean, IVC is one of them. A small and collapsible IVC is one of them, but it's really something that has not been fully played out in the data, to be honest. There's a lot of different ultrasound parameters that you can look at, which we kind of talked about a little bit. Some cardiac, some, a non-cardiac. But so far, IVC ultrasound seems to be the main one at this point. But I think that's probably something, ultrasound still being within nephrology relatively in its infancy. I think that's probably something we'll see better data at some point.
Treya, I would say for me, the biggest thing I'm taking away is even now as a medicine resident, when I have dialysis patients in the hospital, I should kind of be assessing how they've been these past couple months and if I think their dry weight has changed, if that's something they should tell their nephrologist.
Totally fair.
So to recap this case, POCUS doesn't have to stop in the hospital. We were in the dialysis center, patient was short of breath, and with POCUS, we were able to help realize the patient actually had more fluid to pull off, and we were able to lower their drive weight. And yes, it seems like we can all look out for more studies validating lung POCUS and VEXIS in the outpatient dialysis settings.
Let's move on to our final case. We have a 63-year-old male with a past medical history of CKD5 who presents to the emergency room at 7 p.m. with a BUN of 140, potassium of 6.7, and obvious uremic symptoms. You tell the patient that he needs to start dialysis, and he looks at you and asks if his fistula is ready to be used. He said he had an outpatient fistula placed a few weeks ago. So, can we use this fistula, or does he need a temporary line placed?
Can we skip a line that's invasive, that's a higher infection risk, and can we just use this fistula? So, let's just say this is late in the afternoon, you're not going to get your vascular ultrasound, your AV fistula ultrasound to tell you whether it's ready or not. Again, what are your options? To grab a probe and kind of do it yourself. AV fistulas can take a little while to mature, like 6 to 12 weeks, and we're not far off from that, but we're technically a little early, and they still have some insignificant failure rates. So there are some rules, which we'll say, I don't really want to go too kind of in-depth on, but essentially the characteristics that may tell us whether a fistula is more likely to be mature than not. So the classic dogma is the rule of sixes, which is kind of a flow, which is really going to be determined based on your Doppler. The vein diameter is greater than 6 millimeters, and the vein depth is less than 6 millimeters. There's one study really on this, and I think this is a really fascinating study because I think this is something that hopefully will allow for more research on this topic because, avoiding temporary dialysis lines, I think, is a really good thing for a patient. But it's a study that essentially actually had nephrology fellows perform a point-of-care ultrasound on an AV fistula 4 weeks after it was created. And they were comparing that to kind of a retrospective standard of care. And what they actually found was that if the AV fistula had certain characteristics, they were actually able to successfully cannulate it earlier. It was about 35 days versus kind of 63 in the standard of care group, which led to fewer infections and shorter central venous catheter duration and did not have any adverse outcomes on the fistula. So I think that's the kind of study that I think is really fascinating and, hopefully will, again, spawn more to kind of say how safe this is or not.
I think that's really cool because I really feel for this patient because you see so many patients in the ED who aren't able to have their fistula placed. And for the patient who did everything right, they got their fistula placed to go to the emergency room and still need the catheter. Sounds awful. So I think
definitely.
This is super exciting to be able to, at 7 p.m., without needing a formal ultrasound, vascular surgery, be able to put the probe there and figure out what needs to be done.
So we wound up actually, cannulating the fistula and the patient was able to start dialysis without obviously needing a temporary line.
Awesome. That was another fantastic case. So I guess if we can pause here, I'm so curious to ask the room, are you more of a fan for POCUS for AKI or POCUS for end-stage renal disease? If you had to kind of choose between your two children.
I think it's probably intrinsic into at least the ICU nephrology part of me. So I think I probably will say AKI just because, it's more of my area of interest, we'll say. But again, both great teams. But I'd love to hear your guys' takes.
Oh, man, usually for me, I'd say I'm a sucker for those things that make us rethink the things that are lingering around in the one-liners. So that case number 3 where we got to rethink the chronic cough and actually make her symptoms go away. That made me so happy. But it is hard to overlook the benefit that we get from all these AKIs that are coming in and helping people get more dry because we have POCUS and VEXIS. So I surprisingly think I'll give it to the POCUS for AKI crew.
I can't believe I'm going to be different than everyone else, but we've all heard about cardiorenal syndrome, POCUS for AKI. I didn't even know it was possible to do POCUS as an outpatient. And I think the thought of doing POCUS in your outpatient dialysis center and really improving these outcomes for dialysis patients is awesome. And also the thought of saving that emergency room patient to have a line placed at 7 p.m., I think it's really cool. So I'm going to vote for POCUS for ESRD.
And we will see where the votes come in and where we land in terms of March Madness champion.
So Treya, this episode has really gotten me excited about POCUS. I think for my generation of doctors specifically that gets to grow up with it, I just laugh thinking about how the stethoscope has been a symbol of doctors for so long. And I wonder if just in 20 years, all the graphics are going to be replaced with a doctor walking around with a POCUS machine and not wearing a stethoscope.
I know, it's so wild to think, but it could very well be in the future.
And full disclosure, Shrey, ever since we sat down to record this, I've been looking at every bladder and kidney I can with the ultrasounds, and I found some hydronephrosis myself and some missed post-renal diagnoses.
That's awesome. That's a huge win. Now, I've been very inspired myself to get better at it. Like, kudos to you that you've been doing it with all your AKI patients. Just like one more shout out to Dr. Jeffrey Cott, who brought all these cases together. We'll link everything about NephMadness in our show notes. If you have a chance, go ahead and vote. We'll link all that. And thank you again, Noah, for helping kind of lead the ship here.
Thank you so much for having me.
Awesome. Take care. Okay, so to recap this pig. Okay, so that's so awful in setting up estimated driveways. Oh my gosh, what a slip. I think I saw the word P for POCUS. I thought it was the nearest word I knew. Bless. Okay, let's do this again.
Finding great candidates to hire can be trying to find a needle in a haystack. Sure, you can post your job to some job board, but then all you can do is hope the right person comes along. Which is why you should try ZipRecruiter for free at ZipRecruiter.com/zip. ZipRecruiter doesn't depend on candidates finding you. It finds them for you. Its powerful technology identifies people with the right experience and actively invites them to apply to your job. You get qualified candidates fast. So while other companies might deliver a lot of hay, ZipRecruiter finds you what you're looking for. The needle in the haystack.
See why 4 out of 5 employers who post a job on ZipRecruiter get a quality candidate within the first day. ZipRecruiter, the smartest way to hire. And right now, you can try ZipRecruiter for free. That's right, free at ZipRecruiter.com/zip. That's ZipRecruiter.com/zip. ZipRecruiter.com/zip.
If you're a podcast host, listen up, this one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle, and I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.